John Taylor, I'm one of the orthopaedic trainees from the UK, presenting on behalf of Mr. Shah and Mr. Batty from Walsall Hospital in the UK, now presenting results of tuberoplasty. Thank you for the opportunity to present to you this morning. I'm going to talk briefly about the background to rotator cuff tears, massive rotator cuff tears, brief literature review, and discuss my study. So as we know, rotator cuff pathology is very common. Rotator cuff tears are commonly found in cadaveric studies and MRI or ultrasound studies. Increasing incidence with age. Most are a result of degenerative process rather than traumatic incident. Symptoms often correlate poorly with pathological findings. And there's several different diagnostic criteria for massive rotator cuff tears, but most people would say complete rupture of two tendons. So there's several treatment options, as been discussed already this morning, ranging from conservative options through to a more complicated repair, partial repair, tendon transfer reconstruction, and then CTA or reverse shoulder replacements. So tuberoplasty involves recontouring the tuberosities to prevent a smooth articular surface. So the preoperative condition shows reactive bony exostosis due to chronic impingement, which causes significant pain and reduced function. And post-operative condition shows recontoured tuberosities, which removes the source of pain, allowing patients to undergo rehabilitation process to strengthen deltoid function. A minimally invasive day case procedure allows immediate rehabilitation, maintains the coracoacromial ligament, which is an important stabilizer, and allows long head biceps tenotomy, which improves results. There's two papers I found. The first one was an open tuberoplasty in 20 patients, showed significantly improved results. 90% of patients had either good or excellent results. Almost 70% of patients completely pain-free, and all patients were able to perform activities of daily living. Secondly, an arthroscopic study of 23 patients, significantly improved constant score. 83% of patients achieved good or excellent results, and 65% of patients completely pain-free. There was a note of concern because several patients exhibited worsening osteoarthritic changes in the joint post-operatively. Our study is set in Walsall Hospital. Walsall is a busy town in the West Midlands with a significant elderly population. It's a busy general orthopaedic centre. So we studied 20 procedures in 18 patients over a 2-year period. All patients had confirmed massive rotator cuff tear, which was irreparable at arthroscopy, and all patients were treated with arthroscopic tuberoplasty. We reviewed the case notes of the patients, in particular the pre-op assessment and operative findings, reviewed patients post-operatively and scored them using the UCLA system, which is an objective and subjective assessment comprising pain, function, range of movement, strength, and patient satisfaction. Procedure: standard beach chair position, standard posterior, lateral, and anterior portals, assessment of the glenohumeral and subacromial spaces, debridement of the remaining cuff and inflamed bursa, debridement of the bony exostosis, and recontouring of the tuberosities to create a smooth articulating surface. We're able to directly observe the articulating surface whilst moving the arm to check for any residual impingement. If biceps tendon was still attached, we performed tenotomy, and if there's any significant AC joint arthritis, we performed arthroscopic debridement at the same time. So the images show on the top left bony exostosis of the tuberosities, show them being recontoured to provide a smooth surface, and the pre and post-op x-rays show a change in shape of the tuberosity. Post-operative management, the broad arm sling mainly just for comfort, immediate physiotherapy, passive and active range of movement. Reviewed patients 6 and 12 weeks post-operatively. And our next step was CTA or reverse shoulder replacement if patients were significantly symptomatic. Our patients range from 54 to 84 years old, mean age 68. Majority of patients were female. Majority of patients hadn't had any preoperative imaging, and there were several patients who had an alternative diagnosis prior to surgery. We performed a tuberoplasty isolated in 11 patients. 5 patients also had AC joint resection. 2 patients had biceps tenotomy and 2 patients had all 3. Follow-up was 3 to 18 months, average of 6 months. The mean UCLA score was 22.7. And 45% of patients achieved good or excellent results, with 55% of patients achieving fair or poor results. The results in more detail show that almost all patients had pain post-operatively, mainly minimal pain only on heavy activity. Most patients had reasonable function. All patients had range of movement greater than 90 degrees forward flexion. Majority of patients had good power, but only 1 patient had full strength. And majority of patients were satisfied post-operatively. So the weakness of our study, unfortunately small numbers in the study, a short period of follow-up, only 1 surgeon in 1 particular centre. There was no preoperative scoring data of which to compare to, and no comparison was made to an alternative treatment. We had unsatisfactory results. The possible reasoning behind that might have been a short-term follow-up, might have had improved results over a longer period of time. There might have been a delay to presentation in our patients as compared to the other studies. And by the time our patients presented, they might have had particularly worse pain and very poor function. It may be that our rehabilitation progress was different from in the studies. It may be a consequence of cuff tear arthropathy, which we didn't take account for. It may be a deficiency in the scoring system. So to conclude, massive rotator cuff tears are a common cause of disability in older people, and the management remains a problem and a challenge. Arthroscopic tuberoplasty is an effective option in some patients, particularly older patients with limited functional demands. But more work is needed to assess the long-term prognosis with the procedure and to further optimize management in this difficult group of people. References. And thank you. Any questions?